So, hello everybody. I am Laura Jardim, and I'm here today to speak about the biomarkers progression during preclinical stages of Machado-Joseph disease according to the BIGPRO study. So, as you well know, Machado-Joseph disease is also known as spinocerebellar ataxia type 3. This is an autosomal dominant polyglutamine disorder due to the CEG expansion presented in the TXN3 gene. We have nowadays convinced data showing that in SCA3 as well in other polyQ disorders, before the clinical phase of the disease, here 0 and 0 meaning the start of the clinical phase of the disease, the start of symptoms. Before this, some parameters, some neurological, neurophysiological, and other kind of parameters present or already present deterioration, small deterioration, but rather present there and suggesting a progression. This graphics came from the RISCA study performed in Europe, a longitudinal study performed in Europe. And these graphics came from our baseline studies here in South Brazil, in which again we have seen that several biomarkers presented a progression, an apparent progression in the pre-ataxic phases of Machado-Joseph disease. So these findings, these evidences, plus several experts showing the opinion that the prevention of the disease onset will be easier to perform than slowing or reversing disease process in symptomatic patients, poses us the question on what to do in this preclinical phase of the life of the subjects that carry the mutation. So before the diagnosis or before the onset, the clinical onset of the disease in a stage may be called preclinical or asymptomatic, but indeed in a stage in which we can do something preventive or modifying. The big challenge is how to develop clinical trials for this stage. Because of that, we think we could be able to help with BIGPRO study. This study addresses a prospective and longitudinal design in which ataxic and pre-ataxic carriers, together with their related non-carriers or controls, would be seen at year-based evaluations, rather clinical, neurophysiological, biochemical, and brain MRIs. Today, I will show you the observations of the three first evaluations related to the clinical scales, video oculography findings, and brain MRIs, and focusing more specifically in the comparison between the pre-ataxics and related controls. This study indeed represented in a good way the PhD of my student Camila Oliveira. So what we have done, we recruited between 2017 and 18 at-risk subjects as well as ataxic carriers of SCA3. The at-risk subjects were genotyped in a blind way so that we have carriers and related controls. Moreover, when we have all the mutation carriers, we again separated them according to the SAR score into ataxic carriers, 35, pre-ataxic carriers, 38, and related controls, 22. The cohort was evaluated according to two different timelines. The first one was the classical study duration time, so in which you compare the baseline results of everybody together with the visit 1 together, and after that to the visit 2. This is the study duration scenario. The second one In the second one, we try to achieve a more natural history approach in which the time to the onset of the gait ataxia into the preclinical phase of the disease was taken into consideration, whereas the time after onset in the ataxic phase of the disease was also taken into consideration. So the subjects were put in this kind of line where the zero means ataxia onset. So the symptomatic or ataxic subjects are on the right side, on the positive side of the line, whereas the pre-ataxic ones in the left side, in the negative values of this line. How did we get this information for the pre-ataxic carriers? Of course, for the ataxic carriers, it's easy to obtain the information. It's just you just need to ask them when the ataxia started. Whereas the pre-ataxic ones, we need to predict this, and we were able to do that. And actually, we had already published by a formula, by an equation that predicted the age of onset of subjects from our geographical region according to the CEG repeat length that they have. So by doing that, we put them here, and moreover, we splitted this pre-ataxic group into two different groups at baseline, at the start of the disease, calling them pre-ataxic carriers far from onset or near onset, based on the percentile 25 of the predicted age at onset. That was indeed 4 years before the predicted age at onset. So these were PAN, pre-ataxic near onset. These are PAF, far from onset. What we have done with everybody, for all participants, in all visits, we performed clinical skills in video oculography. Whereas in visit 1 and visit 3, we added also MRI studies. And finally, in follow-up visits, the patient global impression of change as well. So clinical skills included SARA, ICERS, NASCA, INUS, SCAFI, and CCFS. Video oculography variables included variables that already have shown to discriminate pre-ataxic from controls in this Chinese study, or namely video oculography of the vestibulo-ocular reflex, vertical pursuit, reflexive and volitional vertical saccades, gaze-evoked nystagmus and central nystagmus, this last one. Finally, from the MRI studies, we obtained volumetries of the cerebellum, of the deep gray and cortical gray matters, cervical spinal cord area, as well as DTI for the white matters of the central nervous system. Actually, we decided to follow in the longitudinal study only variables that presented with a p of 0.1 or less after Bonferroni correction at the baseline evaluation. So what were our results? Our baseline results have already been published last year. I just remind you that in the baseline studies, we were already able to show that these 4 clinical scales and these 4 video oculographic parameters were able to detect changes where they showed significant differences in between the pre-ataxic near onset and controls. NASCA, ICERS, SCAFI, INUS, vestibulo-ocular reflex, gaze-evoked nystagmus, vertical reflex, and vertical volitional saccades. Okay. What happened longitudinally? No, of course. On visit 1, the number dropped to 81. Then we had the COVID-19 pandemics that reached all mankind. Yeah. And after that, we have lost the number for 61 subjects. What happened? Nothing happened. It seems that I am still recording the section. So again, we have the pandemics, and then the pandemics produced this drop for 61 subjects evaluated in the visit 3. Well, how the longitudinal scales and video oculographic parameters evolved, progressed according to the time after onset of gait ataxia. Before that, I need to tell you that we have uh, 54% of conversion rate among the pre-ataxic near onset. So these 54% of subjects, or 6 subjects, were not pre-ataxic anymore. They were ataxic at the end of the study. Yeah. So we decided to take this into account into this evaluation according to time 2 after onset by doing what? By separating the carriers group into 3 groups: the ataxic subjects that were ataxic since the start of the study, the pre-ataxic subjects that converted to ataxia, and the pre-ataxic subjects that continue to be pre-ataxic at the end of the study. And by doing that, we have this kind of raw results. And I took NASCA because NASCA was really good, but it happened to almost every biomarker that we follow longitudinally. You can see that it seems that the slope, the velocity of progression of the converters were more similar to the slope of the ataxics since the beginning of the study, these 2 slopes, than those guys that continue to be pre-ataxic. And indeed, it happened when we aggregated the data and obtained the mean progression rates. You see the slope of everybody that were ataxic since the beginning, the converters, and the pre-ataxics. Every time we saw, or in majority of our variables, these slopes of the converters were rather similar to the slopes of the ataxics, or more or less more similar than the slopes of the pre-ataxic group. And because of that, we decided to merge the blues and the green ones, or all ataxic subjects at the end of the study, into a single group. So we have now only 2 groups: the ataxic carriers at final visit and the pre-ataxic carriers at final visit. What we have seen was that all clinical scales and half of the video oculographic parameters presented significant progressions in the ataxic group at the final visit with these effect sizes. Again, the largest effect size belonging to Sarah in the ataxic group, whereas in the pre-ataxic group at final visit, the significant progression occurred in NASCA, in Innes count, and vestibulo-ocular reflex, only with these effect sizes. 5 of 6 clinical scales presented this accelerated deterioration 4 years before the onset of ataxia. So you are always seeing this curve that suggests a quadratic progression, whereas the transition was not so intense in 4 out of 6 video oculographic variables. It seems to be more continuous during the life of the subjects, into the comparing the pre-ataxic and the ataxic periods of life. And what happened when we follow these guys according to the study duration? The study groups were the same as I presented in the baseline. The study groups, according to status at baseline, were ataxics, PAN, PAF, and controls. And according to the study duration, the ataxic carriers presented significant progressions only of all clinical scales, and There were no progression rate of videochoreographic parameters according to study duration in the ataxic subjects. There were no progression at all in the pure ataxic subjects far from onset, but there were progression rate of NASCA and of the vertical pursuit gain in the pre-ataxic group near the predicted onset of gait ataxia. So the effect sizes were rather interesting here in these three groups, at least three scales, SAR and NASCA Nikers in the ataxic carriers, but in the pre-ataxic carrier group, the effect size of NASCA was rather large. Yeah, this is the progression rate of only NASCA. I took only NASCA here to appreciate the differences in the progression rate of controls, PAN, near onset, and ataxic group. And about the MRI results, you remember that I will present only the pre-ataxic versus related control results on MRI. So we have this number of subjects. And the first question was, what MRI structures distinguished pre-ataxic from controls at baseline? These were the right inferior cerebellar peduncle, here, and here, according to any kind of DTI evaluations, FA, MD, RD. We have differences in the pre-ataxic versus related controls that were significant. Also, in the left and right medial cerebellar peduncle, according to mean diffusivity, differences were significant, and also according to medial lemnisci, especially the right one. Again, differences were significant. Finally, the cervical 1 area of the spinal cord, which was smaller in the pre-ataxic than in the related controls. So all these variables of these four areas of CNS, of central nervous system, presented correlations also with the size of the CEG repeat length in the expanded allele at baseline, the correlation being more strong when the right inferior cerebellar peduncle was assessed. The final question about baseline results was what variables correlated with clinical skills at this point, and we obtained this correlation in between right medial lemniscus against NASCA, only that. Okay, longitudinally, MRI were obtained from 17 pre-ataxics and 12 controls that completed the two observations, and we followed up 13 variables that were selected according to that a priori inclusion criteria that I mentioned before. Okay, none of the 13 variables progressed after 2 years in the study duration evaluation in the pre-ataxics. Whereas when we went to the time to onset evaluation, when it put them according to the time that it will take to each one of them to be converted to ataxia, we obtained these 5 alternatives after correcting for age, sex, and total intracranial volumes. According to z-scores for age, we saw a significant progression in the pre-ataxics, all pre-ataxics again, now, all pre-ataxics now, pre-ataxic subjects in the right inferior cerebellar peduncle, which were smaller in the pre-ataxics than in controls, the right and left medial lemniscus, and the left middle cerebellar peduncle. These areas, according to DTI, changed significantly in 2 years scenario with these effect sizes. And about the conversion rate, especially of pre-ataxics near onset. I told you that we have 54% of conversion rate. Well, this percentage allowed us to estimate that for a future clinical trial with 80% of power, 2 years of follow-up, and an alpha of 5%, 57 subjects pre-ataxic near onset would be needed per arm of the study to the study detect a 50% reduction in the conversion rate of the arm under study. So this number is very interesting, 57, but I need to remember that pre-ataxic near onset are not that frequent, of course. Yeah. So going to the final part of my talk, the discussion, what can we tell you about future trials from this longitudinal observation? Well, we can tell you that some biomarkers discriminated pre-ataxic carriers near onset from controls, and that they were these 4 clinical scales, and I would say the best one was NASCA. These 4 video-oculographic parameters, the best one being vestibulo-ocular reflexes. And that when we move to the MRI, then the question changed as well, because then I need to ask what biomarkers discriminate all pre-ataxic carriers from controls. And then that they will be the changes in the inferior cerebellar peduncle as measured by all forms of evaluation of the DTI, the right medial cerebellar peduncle, according to MD, the right medial lemniscus, according to all parameters of the DTI, and the cervical 1 area. They were able to discriminate all pre-ataxic carriers from controls. What biomarkers progressed in pre-ataxics when the timeline was time to onset. Now is progression. And in the timeline is time to onset. These 8 variables progressed. Actually, 5 of them came from the MRI and had the largest effect sizes. So the effect sizes for the pre-ataxic period, the best ones, came from MRI again. Okay. I need to stress that clinical scales that progressed in the pre-ataxic period were those that are not related to ataxia. Yeah. As well, in the time when the timeline is the study duration. The biomarkers that progressed in the pre-ataxics were NASCA and vertical pursuit gain. With these effect sizes, again, 2 variables not related to ataxia. In spite of that, I need to stress that responsiveness were higher with SAR and ICERs. I had no time to talk about responsiveness today to you, but we measured responsiveness for all variables under study, and the best ones were SAR and ICERs. This means that ataxia is the most important disability, at least as perceived by the subjects. So according to their impression of change. And because of that, the Sarakutov to separate the 2 phases of life of carriers, of SCA3 carriers, is warranted because it's important. It has very signification. The meaning of this for them is very important. And I will explain better now. For future trials, in preclinical phases, the effect sizes were really small for all variables during this period of their lives, pre-ataxic period, when there is no form to evaluate responsiveness, because subjects doesn't have symptoms. So what they will perceive as change, they will not have responsiveness as well. Okay. The conversion rate as an outcome for future clinical trials in pre-ataxic period is very interesting, because conversion rate allowed reasonable sample size, at least for pre-ataxic subjects near onset of predicted age at onset, and because it will have certainly clinical meaning for carriers. They don't want to be ataxic. We need to remember that. So We suggest for the future clinical trial in pre-ataxics that these studies estimate the predicted age at onset of the participants and use time to onset as the timeline. Second, that they should recruit pre-ataxic carriers near onset, preferably. Third, that they use the conversion rate as the primary outcome. And fourth, that they use DTI variables, vestibulo-ocular reflex, and NASCA as secondary outcomes. Finally, a word about pathogenesis. Better saying about how our longitudinal study could help by bringing some glimpses, some tips on pathogenesis. Well, when a clinician like me look at this progression rates in these curves, this clinician should think that this maybe this acceleration in the speed of progression 4 years before the onset of gait ataxia maybe in some way is reflecting the disease process in the brain. Maybe the disease process in the brain started more robustly also some years before the onset of gait ataxia, because here with the progression do exist, but it's rather small. However, we had 4 parameters that presented a rather smooth or seemed to have more smooth progression during life of the carriers, before ataxia and after ataxia. And because of that, these curves, this progressions apparently more continuous, poses the doubt on the exponential progression or quadratic progression, that maybe these progressions should be due to scale properties rather than to pathology, to floor effects of the scales rather than to the pathogenesis in central nervous system. Regardless of the reasons underlying this apparently quadratic curves, underlying the shape of this progression curve, we need to finish by saying that the current instruments that I presented today could be more effective for future clinical trials in pre-ataxics if they will be used close to the onset of gait ataxia, some years before only. This is our final message from our study, which was unicentric. It happened in Porto Alegre, Rio Grande do Sul, and it was longitudinal. This study had actually 2 senior investigators, Maria Luisa Saraiva Pereira at molecular studies and myself on clinical studies, whereas all these researchers were students at the time of more or less the beginning of BIGPRO study. At the beginning of BIGPRO study, Camila started her PhD studies, and now more than 4 years later, after that, as the participants reduced in number to 61, also the researchers were reduced in numbers. But again, here we are in 2019 when we presented the baseline results of BIGPRO study. So now I am presenting longitudinal data, and because of that, I am very grateful for all the researchers that are working with me all these years, as well as the funding obtained from the Brazilian institutions. And again, very thankful for your attention. Thank you again.